Hello, everyone, and thank you for the opportunity to talk with all of you. We all know it's an exciting time to be in oncology with all the new drugs and all the new treatment options we have for our patients and improving overall survival for our patients. It was a great talk to hear about the breast cancer. We are not as close as breast, but even in GI, I would say we have made a lot of progress in all the cancers, going from colon cancer to pancreas cancer. So I'll give you a few updates in terms of screening, treatment options we have for the GI cancers. So we'll start with colon cancer. So the first update, I would say, is a screening for colon cancer. We did hear about breast cancer screening with the mammograms. For colon cancer, we all have been informed that it's 50, the starting age for screening for colon cancer. But in the last 4 years, the recommendations have changed, and American Cancer Society gives the recommendations to start screening colonoscopies at age 45 now. And that's because I'll show why. And USPS Task Force, which is the main guidelines which the primary cares use, also changed their recommendations to start screening for CRC at age 45 instead of 50. So what does this mean? It means like there are almost like 20 to 20 million Americans who will be eligible for screening immediately because of the change in the recommendations. So why is this change so important? What we have been seeing, I think maybe you guys, all the nurses have been seeing in the infusion areas too, that we are seeing more and more younger patients with colon cancer. I would say more like 30s, 40s than like 50s and 60s. I would say 50s and 60s, they go to screening recommendations and do the colonoscopies, but in 20s and 30s, the symptoms are so non-specific that they don't even think of doing a colonoscopy. But what we have seen that since early 2000, the incidence for patients among 45 to 50 years of age has definitely increased. What it means is 1 in 10 have been diagnosed with CRC or below age 50. So the projections are like by 2030, if you see the colon and rectum, the increase is so high that we are seeing. Why is it? Why is it like we are seeing more young colon cancer? And that's the first question I get asked. We know that risk factors, mostly the common risk factors are the diet, with increased consumptions of red meat, saturated fats, decreased fruits and vegetables, obesity, and especially with the COVID too, with a lot of people working from home and inactivity, I would say that's also adding. Smoking, alcohol, diabetes. But most important is like there have been a lot of research going on in the gut microbiome, especially in colorectal cancers. They're trying to see like what's the thing. We all have like bacteria in our gut, which is protective for us, but it looks like with all these risk factors, there is change in the microbiome, which is causing alteration and causing increased inflammation in the GI tract, leading to increased incidence of colon cancer. So there's still a lot of research going on, and we have been having more and more papers coming up in this, and I think we'll have more information in future about that. And also, we all know that patients who have family history of like colon polyps or Lynch syndrome or any polyps, make sure if you hear from your patients, get their family members also get screened for the colon cancer. So the recommendations at this time are for all adults aged 50 to 75, definitely grade A recommendations for screening. For 45 to 49, it's grade B, but it's going to be grade A soon. And after 75, the screening depends on patients' comorbidities and how fit they are and if they want to continue the screening. And you continue screening till they want to do up to 80 to 85 is the oldest patient I have been screened was 85 because the patient was very in perfect health. So that's about the screening. So then coming to the treatment options. So if you look, we all know that stage 1, 2, and 3 for colon cancer are curable, right? Stage 4 is metastatic, where it's not curable. And stage 1 and stage 2, we just do surgery and no chemotherapy for them. And stage 3, it's definitely chemotherapy because the risk of recurrence is almost like 40 to 45% for these patients. So what are the updates in this? So in adjuvant side, the 2 updates which we have is the IDEA trial, where we looked at like, is less chemotherapy enough for patients with stage 3, or do they really need like more chemotherapy? And the other thing is circulating tumor DNA, which I'll go over, which is helping us to avoid unnecessary chemo for stage 2 or even following stage 3 patients very closely. So the first one is a circulating tumor DNA. So what this test is, it's related, just got it pre-approved. So what we are trying to do in our early stage colorectal patients is follow them very closely even before they have the symptoms to detect their cancer recurrence. So it's mainly blood draws, which we draw blood for patients periodically, and sequence their circulating tumor DNA, and they compare it to the patient's original biopsy. And this was a study which looked at like patients, and they followed according to the regular recommendations like CEAs and CAT scans for these patients. And what they did was like, this one is to just show that after adjuvant treatment, in patients who had circulating tumor DNA positive versus negative, patients who had tumor DNA positive had definitely high chance of recurrence, almost up to 80% compared to patients who had negative DNA. So this is one more test just to reassure the patients that, okay, they are being closely monitored, because once the patients are done with the treatment, it's the anxiety. Am I cured? How can you say I'm cured? What if how do I know that? It's one more reassurance for the patients is what I would say. And also, this is also helping us like to show that we always do CEA for our patients and CAT scans, right? So it looks like the lead time from this test compared to the CT scans and the CEA is almost 8 months. So how do we use it? Like, if you have a patient whose ctDNA is positive after they are done with their adjuvant treatments and we are following them, so we may follow them more closely compared to 6 months. I might see them every 2 months and be a little bit more aggressive in their follow-ups. And also, this test is helping in our stage 2 patients. Stage 2 patients, we assume like it's almost like 80% chance of cure just with surgery alone. But there are some stage 2 patients who are very anxious and they are like, do we need to do chemotherapy or not? But we don't want to do more harm than do benefit for these patients. So there is a trial going on for stage 2 patients at this time where they are randomizing patients based on the tumor DNA to see doing like adjuvant chemotherapy for these patients is beneficial or not. So I think we'll be hearing more and more about this use of tumor DNA in future more aggressively for our patients. So then comes this IDEA study, which is based on chemo patients. For all our stage 3 patients, we recommend chemotherapy with either FOLFOX or Zelox, which is 5-FU and oxaliplatin. But the main thing, I know you guys see more than us, is the oxaliplatin toxicity, where patients can react to oxaliplatin or they have the neuropathy, and it's the most common complaint for us. So this trial looked at to see, do these patients really need 6 months of chemotherapy, or can we cut down to 3 months of chemotherapy for these patients? So this is a trial where they looked at 6 previous trials and consolidated the data. And what it showed is like, compared to 3 months versus 6 months, if you see that overall survival is almost the same. So it's exactly the lines are just on top of each other, I would say. So then they looked at is Capox, capecitabine with oxaliplatin, versus FOLFOX, 5-FU with oxaliplatin, which is better because some patients prefer oral capecitabine versus 5-FU, which is the IV. So the study also showed that Capox is as good as FOLFOX for the patient. The only thing is in FOLFOX, there is little bit slight change in the curve, and that's mainly what the study showed is FOLFOX for high-risk patients, like stage 3C, where they have more than 6 lymph nodes. FOLFOX for 6 months is definitely better than FOLFOX for 3 months. So for all our stage 3 patients, the new recommendations are we can offer them Capox, capecitabine with oxaliplatin, or FOLFOX for 3 months if they have less than 6 lymph nodes positive. It's only if they have more than 6 lymph nodes positive that we recommend 6 months of chemotherapy for them. So that's a good thing. Less chemo, the better, right, for our patients. So that's one thing. Then coming to the preventive strategies. So patients are like, we are done with the treatment, what next? That's the most anxiety time they have, and what are the things they can do to help decrease the risk of colon cancer, right? So studies have been shown, like baby aspirin, 81 milligram, definitely has shown to decrease the risk of polyps in patients. We always tell patients healthy eating, more fruits and vegetables, less servings of red meat. When they ask me less servings, I say 2 to 3 servings per week is what I recommend for the patients, more exercise. The recent studies have shown that keeping vitamin D levels in the normal range has also helped to decrease the risk of colon cancer recurrence. So this is a pooled analysis of 17 studies where they pooled all patients with colorectal cancers and showed that keeping the vitamin D levels good in these patients has shown to help. So one more thing, patients can take control of their disease to help decrease the risk of recurrence. So these are the preventive strategies. Then coming to the metastatic colon cancer. So definitely we have shown improvement in overall survival for patients. And even for stage 4 patients, if they have like 1 to 2 liver mets or even lung mets, we are aiming for cure for these patients with our surgical approaches. And also, we have definitely added more and more biologics for our patients to decrease the side effects. And also, the exciting thing about in oncology is the use of molecular markers with next-gen sequencing, which I'll talk at the end, where we are trying to help personalize treatment for our patients with colorectal cancers, or any cancer for that matter. So if you look at the survival rate, so for patients with colorectal cancer, without chemotherapy, it used to be 6 months, and with chemotherapy, 12 months. But now we definitely see patients live more than 2 years for sure, and even 5 to 6 years. I should say the longest time my patient I had was like 6.5 years with stage 4 colon cancer, which was very impressive. The patient could do a lot of things and meet his things and do stuff. And we are having patients go through all lines of therapy. We don't have that many lines like breast cancer, but at least we have 3 to 4 lines of therapy, and looks like most of our patients are going through all lines of therapy for stage 4 colon cancer recently. And coming to that, it's more than one disease. How do we classify patients? If you look anatomic location, we are trying to treat right-sided colon cancer different from left-sided. Young patients versus old different. And also stool flora, which I talk a little bit, we'll have more like based on that. And then if you look at the molecular markers, we always, when we have a stage 4 patient, we send molecular markers for every stage 4 patient to look for all these genes, like MSI, which is microsatellite instability, RAS wild type, HER2, BRAF wild type. Why are we doing this? Because not every chemo is for everyone. So this is mainly targeted therapies for these patients based on these status molecular markers. So that's really helping us decrease the toxicity for patients, because we don't want to give immunotherapy, which is like very expensive and also not easy without any toxicities for every patient. So also, just like to tell you the left side versus right side, the importance is, I think you guys have all been administering bevacizumab, which is a VEGF antibody, and cetuximab or panitumumab, which is a EGFR antibody to all our stage 4 colon cancer patients. But studies have shown that patients who have left-sided tumor benefit more getting cetuximab, which is EGFR antibody, compared to right-sided tumors, where bevacizumab or VEGF antibody has shown to help more benefit for these patients. So when we see the patient, that's also one more thing which we try to see, what side is the sidedness and what's the benefit for these patients when we pick the biologics for this patient based on the tumor sided. So that's one thing. And then, so only patients on the left side should be offered cetuximab for the first line is what the recommendations say. And then this is the signaling pathway in the tumor, where we are targeting multiple targets for the patients. The first one is the VEGF, which is the vascular endothelial, where we have targets like bevacizumab, ramucirumab, and aflibercept. the other one is the EGFR, where we have cetuximab and panitumumab, which have been there almost for last 10 to 12 years, I would say, and we all are comfortable with that. But now we are targeting downstream pathways. So there have been a lot of studies looking at the RAS, RAF, MEK pathways, and we have had new drugs approved for in the last 4 to 5 years targeting those pathways, giving us more lines of options for our patients with CRC. So I'll just give, and also, like recently, we have had drugs approved for patients who have microsatellite instability. So what's this microsatellite instability is like repetitive segments of DNA, and what it has been is mostly patients with Lynch syndrome are MSI high, and they benefit from the checkpoint inhibitors. So what's checkpoint inhibitors, right? Like PDL therapies and everything, which has been the most important thing for all cancers, I would say. We heard in the breast cancer about the PDA drugs, and even in GI cancers, every cancer we have PD or checkpoint inhibitors approved at this time. So what's the main thing? Like, it's mainly patients come to say, what's immunotherapy? So mainly what we are trying to do is, like, cancer, tumor cells is foreign to our body, right? So T cells should be active to help to get rid of the tumor cells. But these have protective mechanisms, which are called the PD-1 and PD receptors on the cell surface of the tumor cells, which like preventing the T cells to act on the tumor cells. So the immunotherapy or the checkpoint inhibitors comes and unblocks these receptors so that the T cells get activated and act on the tumor cells. So that's the main mechanism. So I tell my patients, you're just activating your immune system by these PD antibodies, and the immune cells are active to fight against your cancer cells. So that's the simplest way to tell. So this was a key study, which is a keynote. So we heard of keynote studies in breast too. So every cancer has keynote studies. Keynote is mainly pembrolizumab is the drug which has been studied in multiple cancers. And a keynote study 117 is mainly in patients with CRC who have MSI high patients, where it has shown that chemo versus immunotherapy, the pembrolizumab, you have significant improvement in overall survival and progression-free survival. If you look, the progression-free survival has not even been reached for patients with this. And the thing is, like, less side effects compared to chemotherapy, no neuropathy from oxaliplatin compared to pembrolizumab for these patients. And even the duration of response, it's like, you can clearly see the difference in the curves over here with this immunotherapy. So now the new guidelines are for every stage 4 cancer patients, we need to do MSI testing and offer immunotherapy if they do have MSI high for these patients. But the thing is, immunotherapy also has its own side effects. The side effects from immunotherapy are slightly different compared to the side effects of chemotherapy, where you have neuropathy, nausea, vomiting. But with immunotherapy, it activates your immune system, so you can have any itis, is what I say. It could be colitis, it could be dermatitis, it could be pneumonitis, hepatitis. So if patients are having any unusual side effects, just make sure we know and we check for these side effects for these. And we are learning more and more how to manage these toxicities from the immunotherapy too lately. And then, as I said, we knew about EGFR and VEGF. So we have like new data on BRAF mutation positive patients. BRAF mutation is bad prognostic marker for patients with colon cancer. So it's like RAS, RAF, MEK, and ERK. So the new thing is that in the last 3 years, we had a new study which targeted RAF and MEK. It's just targeted therapy, no chemotherapy for these patients. Usually, we use chemo plus targeted therapy, but in this study, which is a beacon study for patients with BRAF mutation positive patients, which is almost 15 to 20% of our CRC patients, they looked at like binitinib and encorafenib and cetuximab, all 3 targeted therapies, versus 2 targets versus chemotherapy. And what the study showed, compared to chemo, targeted therapy was definitely superior. And even in targeted therapy, they compared triplet versus doublet. And the doublet was definitely enough for patients with CRC. So the standard for BRAF positive patients used to use doublet targeted therapy targeting EGFR and BRAF at this time. And then also HER2. HER2, we all know it's mainly breast is where we hear a lot about HER2, but even in GI cancers, we are looking that HER2 tumors are positive for HER2. Not as much as breast. Breast, it's almost like 30% or so. In colorectal, it's only 3 to 4% who have HER2 positive colon cancer. But if they do have HER2 positive, they definitely have improvement in responses to drugs like Herceptin and trastuzumab deruxtecan. This is a study showing that even after 3 lines of therapy, giving HER2 targeted therapy did have objective response rate of more than 30% in these patients, which is good for our patients after 3 or 4 lines of therapy, I would say. And then we heard also in breast cancer about HER2-targeted antibody drug conjugate. So there have been studies looking at this. So this is HER2, where you link and chemo also to the HER2-positive, HER2 link. So that's about the colon cancer. And coming to the rectal cancer, the only thing I would say the updates is, for rectal cancer patients, for early stage, we always do like chemoradiation followed by surgery is what we have been seeing. What the studies have been looking at is like after surgery, these patients have a hard time tolerating any adjuvant chemotherapy if they need. So they're trying to look at total neoadjuvant therapy, where we are trying to do chemo and radiation, and also chemotherapy upfront compared to surgery and then chemotherapy. And studies have definitely showed, like if we do all total neoadjuvant therapy, there is decreased risk of local recurrence and also distant metastases for these patients. So that's the update, I would say, in rectal cancer. So these are the conclusions where we have decreased the age of 45. We are using ctDNA, and less chemotherapy, the better. And immunotherapy has been approved for CRC patients, and also more and more targeted therapies coming up. So that's about the CRC, which is the big bulk of our GI cancers. But also, I thought like there's been a lot of research and updates in gastric and hepatocellular and pancreas too. Coming to the gastric, the important study I think we all should definitely acknowledge is for esophageal patients. We use trimodality therapy. These patients get chemoradiation followed by surgery. And even after the trimodality therapy, for early stages like stage 2, 3, they have almost 50% chance of recurrence within 4 years after the trimodality therapy. So there was a study which came up, and we are using this, is the Checkmate. Checkmate is mostly nivolumab, and Keynote is mostly pembrolizumab. So this Checkmate study for patients who have like a residual tumor at the time of surgery, or if they have any lymph nodes positive still. For those patients, the current recommendations are just follow them with like periodic scans, and they have recurrence, treat them. So what this study did was for those patients who had residual disease, they randomized them to nivolumab, which is the immunotherapy, for a year compared to placebo. And the results very impressive, where compared to placebo versus nivolumab, the disease progression-free survival was almost double. So the standard is for all the patients who have any residual disease, we are using immunotherapy for a year for these patients at this time. And then it's like immunotherapy everywhere in all cancers. So even in esophageal and GI cancers, they are trying to get immunotherapy to first line. So we have a lot of studies, like if you look at the study Keynote 590, which is a pembrolizumab study in the first line, and then the Checkmate study where it's nivolumab in first line, and then Keynote 811, that's for HER2 positive patients in first line. All these studies, it's like so much information in the last year that we are using immunotherapy in first line for both HER2 positive and HER2 negative patients. So I would say we heard about PDL expression in the previous talk to, I just wanted to say, like, what's PDL expression, right? What are we looking? So it's mainly on the tumor samples. We are looking at the expression where it's PDL positive staining cells. It's related to tumor cells, lymphocytes, and macrophages versus total number of cells is what we do. And we give a score. It's CPS 1 to 10 is the score which has been given. And that's how we use immunotherapy for patients. If you have CPS score high, the more the benefit of immunotherapy compared to CPS score of low. So I thought this would be just for us educational information. So this is a study which changed our first line for GE junction and esophageal and gastric patients, where they, stage 4 patients, they randomized patients to nivolumab and ipilimumab, 2 immunotherapies versus immuno plus chemo versus chemo. And based on this study, the new recommendations are for any CPS patients. This study had benefit for CPS high versus low. Immunotherapy with chemotherapy did show definite improvement in survival by 3 months. So that's the study based on which the new treatment options for our first-line patients is immuno plus chemo. And for HER2 positive patients, also, like we all know, HER2 positive is bad prognosis for any cancer. Like how we heard in breast cancer, even for GI cancers, HER2 positive is bad prognosis. But HER2 positive is almost 15 to 20% in gastric, I would say. So this is how we get the HER2 tested with IHC and FISH, as we know. And the first study which we had was we would use chemotherapy plus trastuzumab versus chemotherapy, definitely showed improvement by adding trastuzumab, and that's what we have been doing. But the new study which came up using immunotherapy again, adding immunotherapy to chemo plus trastuzumab, definitely had improvement in overall survival for the patients. So for HER2 positive patients, we add immunotherapy as well as Herceptin for these patients in the first line. So that's the new recommendations and updates for the thing. And we are having studies also looking, again, trastuzumab deruxtecan. We also have a DESTINY trial in gastric too, like in breast we just heard, where they used patients after 3rd or 4th line treatment, they still responded with trastuzumab deruxtecan. So that was really impressive that we could use it after 3 or 4 lines of therapy and still have response rates of almost 40% in these patients. So then next is hepatocellular cancer. So for HCC, I think so far the only drug we had until 4 or 5 years is sorafenib or Nexavar. That's the only thing I learned in my fellowship, and that was the only thing I was giving for my patients. And the other options were like embolizations. Those were the options for our patients. But in the last 5 years, it's really impressive that we have so many new drugs approved for HCC. So if you look at CN guidelines, even for first line, we have preferred regimens, which is atezolizumab and bevacizumab, which is immunotherapy plus targeted therapy. And then in targeted therapies, we have lenvatinib, which is approved for first line, and then nivolumab approved for first line. So HCC, we don't use chemotherapy at all. It's just immunotherapy or targeted therapy. And that's really impressive. Like, this is a trial which got our first-line approval for HCC patients, where we are using atezolizumab, which is immunotherapy, and bevacizumab, which is a targeted therapy, which targets the blood vessels. And they compared it to sorafenib, and there was definitely improvement in overall survival, as well as progression-free survival for these patients. So the first line for all our HCC patients, if they have good liver function status, which is we classify patients as child PU A, B, and C. For child PU A, the standard is to use immunotherapy, atezo plus bev for the first line patients. And even in second line, we didn't have anything, and you can see like we have almost 1, 2, 3, 4, 5, 6 options for our patients with HCC for second line. I think the main thing where we lose use this is like if their liver function gets worse because of cirrhosis or so. Otherwise, if patients have good liver function, these patients can get through all these lines of therapy. So it's really impressive that we have, and these are all targeted therapies, right? If you look at these studies looking at regorafenib, which is an oral targeted kinase TKI, cabozantinib, another TKI, and ramucirumab, an antibody, compared to placebos, there's definitely improvement in overall survival for these patients. So HCC, more and more coming too, and they are looking at more combinations still with a lot of studies. Last but not least, we should definitely talk about pancreatic cancer. So pancreatic cancer, we all know that by the time these patients get diagnosed, it's almost stage 4, where you can see like 50% of patients have stage 4. And localized, it's only 10% of patients have localized pancreatic cancer. And the 5-year survival rate too, you can see it's been very low. So I would say like 15 years ago or 10 years ago, I would say with or without chemo, the overall survival is 6 months, and we had only one drug, gemcitabine. That was the only drug we had approved until recently. And then you can see the approval of the drugs. So from until 1994 to 2006, we had only gemcitabine. Then came erlotinib. Erlotinib is an oral TKI, but it added only 2 weeks of improved overall survival for patients, so that was not a big thing. But then we had FOLFIRINOX, gemcitabine, nab-paclitaxel, nanoliposomal irinotecan, olaparib, which is a PARP inhibitor. So we have definitely improved overall survival for patients up to 2 years, I would say, with pancreatic cancer with all these treatment options. So the first line, it's gemcitabine, nab-paclitaxel, or FOLFIRINOX, depending on patient's performance status. We pick one or the other. And if they start with one, they go to the other. And for patients who have good response, we go with maintenance treatment with PARP inhibitor with olaparib. And second line, we have nanoliposomal irinotecan. So these are the trials looking like, compared to gemcitabine, definitely gem-Abraxane has improved overall survival. And it's relatively tolerable treatment, I would say, for these patients. Like even patients in their 70s and 80s tolerated relatively well. Compared to FOLFIRINOX is a little bit toxic, but it's mainly for younger patients and also for borderline resectable patients. We are using this regimen to get them to resectability. And as I said, olaparib is used as a PARP inhibitor for maintenance. And also for every pancreatic cancer patient, we do genetic testing nowadays to look for BRCA gene mutations, because if they have it, we have one more line of option for these patients. And then I would say this is what we are looking at, biomarkers and therapies. So if you look each cancer, we are looking at all these biomarkers for these patients and targeting the therapies. So I would say we are getting close and close towards personalized treatment, select the right treatment for every individual patient. But I think we still need to do more in terms of research and treatment options for our patients. Okay, thank you. Okay. Yeah, so the question was, with ctDNA positive results but no visible disease on imaging or labs, you don't treat but wait, correct? Yeah, we do wait, I agree. Like we watch them very closely. As I said, there are some trials going on for early stage 2 patients, randomizing them to treatment versus no treatment. So there was one more question with ctDNA. In your practice, using it to make treatment decisions, example, patient is negative ctDNA, had intolerance to treatment. Can you discontinue the treatment for those patients? So that's a good question. That at least reassures us, okay, the patient has negative ctDNA. Maybe they should be okay at decreasing the dose or even stopping and watching them very closely, because we have another tool to follow these patients.